So this presentation is about blood gas analysis. Sometimes we refer to this as acid-base balance. The specimen we use for blood gas analysis is arterial blood. We should remember that this is obtained by doing arterial puncture on certain sites. For example, the radial artery, and then the brachial artery, and the femoral artery. So those are the three most common sites. And that arterial blood is bright red in color compared to venous blood. So this would evaluate the function of the lungs to transport oxygen and remove carbon dioxide. We have some terms that we should be familiar with, right? So let's start. Partial pressure of oxygen or PO2. This is the amount of oxygen, dissolved oxygen in the blood. PCO2 or partial pressure of carbon dioxide, the dissolved carbon dioxide in the blood. Of course, we know of pH. This is the potential of the hydrogen ion concentration. Here, we refer to pH of the blood. And bicarbonate, so this is an ion that is usually part of a buffer system in the blood. And then oxygen saturation, SO2, and oxygen content, total oxygen content, CtO2. This is reflective of the percentage of oxygenated hemoglobin. PO2 is an indicator of how much oxygen was able to diffuse through the alveolar membrane going to the blood, while PCO2 is the opposite process, so carbon dioxide passing through the alveoli going outside to the exhaled air. pH is a measure of alkalinity or acidity of the blood. There are four different buffer systems in the blood, and bicarbonate carbonic acid buffer system is considered to be the most important. The SO2 and the CtO2 are reflective of the amount of oxygen that is dissolved and bound to hemoglobin in the blood. The total oxygen content or CtO2 is the sum of the oxygen present in hemoglobin and the dissolved oxygen in the blood. PO2, as we mentioned, requires pressure, and that is about 90 millimeter mercury to pass through the alveolar membrane. Hypoxemia, which is the low level of PO2, may actually result from starvation of oxygen in tissues. The hemoglobin level is decreased in case of anemic hypoxia. So I hope that is clear. One of the factors that ensure that there is enough amount of oxygen in the blood is the affinity of oxygen to hemoglobin. For example, if there is hypoxia, there will be an increased affinity of fetal hemoglobin to oxygen. The degree of association or dissociation of hemoglobin with oxygen would depend on the PO2 and the affinity of hemoglobin to oxygen, which is dependent on the following factors: temperature, pH, PCO2, hemoglobinopathies, and the concentration of 2,3-diphosphoglycerate. Oxygen dissociation curve for human hemoglobin in different plasma pH but constant PCO2, which is about 40 millimeter mercury, and 2,3-DPG of about 5 millimoles per liter, and a temperature of 37 degrees. The curve will shift to the left in conditions of alkalosis and to the right in case of acidosis. The shift to the right causes an increased PO2, PCPO2 level and at a given SO2, so the oxygenation of tissues is greater. If the hydrogen ion concentration PCO2, 2,3-DPG, and the temperatures are increased, there will be a decrease in the affinity of hemoglobin for oxygen. It will cause a shift to the right. The patient's oxygenation status is the main determinant for the PO2 result. This will then result in less than 60 millimeter mercury of PO2, which is considered hypoxia. Remember, the normal level should be about 90 millimeter mercury or higher. PO2 decreases normally with age. There are many different arterial blood gas analyzers in the laboratory, and they are capable of measuring pH, PCO2, PO2, and bicarbonate simultaneously. Some can even measure the SO2 level, right? And the specimen that we use for the determination of arterial blood gas parameters is arterial blood. So they should be collected as we mentioned earlier, and the um, blood collection receptacle that we can use can be a syringe, the plastic syringe, the glass syringe, which is ideal, or the vacutainer system. The anticoagulant that should be used is heparin, and we must prevent the presence of bubbles whenever we do blood collection for blood gas analysis, and we should seal the needle immediately with cork or the stopper to prevent leakage of gases. For each of the different parameters, we make use of different electrodes that are selective for the different substances. For example, for pH, there is what we call the glass electrode and the silver chloride, which is the reference electrode. So the principle behind this analysis is called potentiometry. The PCO2 electrode is based on the pH electrode, but instead of measuring the change in the potential, we check for the change in the pH against the reference electrode. The PO2 electrode is also what we know as Clark electrode. So it has a platinum cathode and an anode that is capable of detecting electrons. In this slide, we can see an example of blood gas calculation. For example, if we are looking for bicarbonate level, we can calculate it from pH level and the PCO2 level. So pH, this is the general formula. pH is equal to 6.1 plus the logarithm quantity HCO3 over PCO2 millimeter mercury times 0.031. So by doing the necessary transposition, we come up with this formula. HCO3 is equal to inverse logarithm of pH minus 6.1. So we transpose the pH to the other side, multiplied by PCO2 times 0.031. So this is what will remain if this is a quantity, if this HCO3 is transposed to the other side. It's inverse logarithm. Right, so we have here some example calculation. If the PaCO2 level is 35 millimeter mercury and the pH is 7.35, we can substitute the values. Inverse logarithm 7.35 minus 6.1 is equal to this value. Right, so 7.35 minus 6.1 is 1.25. Inverse log is equal to 17.8. And then the other quantity is PCO2 multiplied by 0.031. 35 times 0.031 is equal to 1.08. Then we multiply these two values together, we come up with 17.8 times 1.08 is equal to 19 millimoles per liters. So we already emphasized the things that we have to remember when we are collecting blood gas specimens. It should be heparinized sample, right? Both in arterial and capillary samples, although most of the time we make use of arterial blood. There should be without any bubbles, and we should place it on ice, in ice, okay, if we expect delay in transportation. We can also utilize the dorsalis pedis artery, and for infants, we can use capillary blood. Right, so for quality control, so we need to remember the same things as before. There should be um, rules, application of rules, the West Guard rules, or other method to identify errors. We should run the necessary control and standard. We should validate the result and detect for any errors. Quality control should be performed daily and following calibration. Results should be plotted on the chart and rules applied. Okay, quality control rules will help to determine if current patient results are acceptable. Sources of error. So we know that the only anticoagulant that is allowed in arterial blood gas analysis is heparin. So if we fail to add the anticoagulant or if we use other anticoagulants, it may interfere with the analysis by altering the pH. Also, if we fail to obtain the correct specimen, which is arterial blood, and instead we make use of venous blood, that will also affect the result. Proper preservation of the specimen is very important. We should make sure that it is not opened because oxygen and carbon dioxide may be released in the process. And if we do not use ice to preserve the specimen, and if it has been like for a long time, drawn for a long time, so it will become erroneous. These are the levels, reference ranges for adult arterial specimen. The pH should be between 7.35 to 7.45. PCO2 is 35 to 45 millimeter mercury. HCO3, 22 to 26. 83 to 108 millimeter mercury for PO2. Right, documentation. So this is to avoid post-analytic results. We make sure that the correct information are encoded or reported, and we should keep this record in the laboratory for the significant amount of time.